Dear colleagues, ladies and gentlemen, good morning from Athens. My name is Nikos Dimitropoulos and I'm the president of the Hellenic Society of Breast Radiologists. I would like to welcome you in this webinar concerning innovation in breast radiology. Innovation means novel, means new technologies, new software, new materials, new way of using existing technologies, new ideas. Technological developments and innovation in breast radiology is the way to detect breast cancer in smaller size, reducing mortality. This Saturday morning, 11:37, will be the spring equinox, which is the official start of this spring in the country in the northern hemisphere. Spring equinox is always a new start for nature, so I hope that this webinar will bring to you the fresh air of the spring. I would like to thank the members of the board for their contribution, ideas and help. To thank all the supporting companies for their generosity in helping the organization of the webinar. To thank all the speakers that very well embraced the project. All famous professors and directors that will present their experience and clinical results. To thank the coordinators of the sessions and commentators, surgeons and radiologists that will add their experience concerning patient management. COVID-19, besides all problems, has brought a new way of keeping the knowledge. This is webinars, an easy way of being all together, presenters, coordinators, and participants, each one from the home comfort, joining for the distribution of knowledge and experience. Today, we have 30 speakers and 1,000 registrations. I hope you will enjoy the meeting. Thank you all. And it's time now to proceed with the main program. I pass the microphone to Professor Giatas, coordinator of the first roundtable. Professor Giatas.
Good morning, ladies and gentlemen, good morning, and welcome to our webinar entitled Breast Radiology Innovation Course. We're just about to start the first table, and please note that answers and questions will take place after each lecture. Due to the time shortage, the presenter will ask two to three questions live, and the rest will be answered by chat or email. Although breast cancer mammography screening enables early detection of breast cancer, mammography represents issues such as variability between radiology readings and shortage of radiologists. This area of medical imaging is where artificial intelligence could make the biggest difference and improve patient outcome. Our first presenter is Dr. Axel Grevengold, who is a radiologist in Paderborn, Germany, co-owner of the Center Radiologie am Theater and co-president of ECIBC European Guidelines Initiative on Breast Screening and Diagnosis. His presentation would be how artificial intelligence can help improve breast cancer screening and diagnostics with 2D and 3D mammography. Please proceed. Dr. Grevengold, please
yes.
proceed.
Yes, I will share my screen. Good morning, everybody, and thank you for the nice introduction and for having me here in this breast innovation course in Athens at the beginning of spring. My presentation's title is How Can AI Improve Breast Cancer Screening and Diagnosis in 2D Mammography and 3D Tomosynthesis. This presentation is sponsored by GE Healthcare. My name is Axel Grevengold. I'm a radiologist from Paderborn, Germany. Wait, okay. About myself, I'm a radiologist specialized in breast imaging, and I work in a private center in Germany, which also runs a unit for the German National Screening Program. I'm also a reader in several European screening programs, and at present, since 2017, I'm clinical co-chair of the Guidelines Development Group of ECIBC, the European Commission Initiative on Breast Cancer. This is my disclosure. I would like to speak first a little bit about the evolution of breast cancer screening. What we have today and for the last 15 years, the standard of care is 2D FFDM based on the assumption of an average risk for all women in a certain age range. Mostly we screen between 45 and 74 years of age and every 2 years. Tomorrow, maybe we will have a change towards DBT screening, also based on the assumption of an average risk for all women, or maybe for groups who are considered of higher risk, for example, dense breast. And in the future, hopefully we will get to personalized screening, maybe based on risk assessment by algorithms. Professor Perhol will show you that later. Now, I would like to present on two studies we have published in January 2021 in the Journal of Medical Screening. One I published together with Paolo Giorgi Rossi from Emilia-Romagna about interval cancers, and the other one I published together with Stephen Duffy from Wilson Institute in London about how reading with tomosynthesis could work. Now, the first one is a retrospective analysis on how interval cancer rate could be decreased by using an artificial intelligence algorithm in the reading process of two-dimensional full-field digital mammography, because that's what we have at the moment. What was the idea for this study? Interval cancers are defined as cancers that are detected after a negative screening result and before the next screening round. Reasons for interval cancers are several. Either they grow in the interval, that's the true interval cancers, or they are mammographically invisible, which would be occult interval cancers, or lesions in the screening mammograms are misinterpreted, or they are truly missed. This is self-explaining. In all screening programs, the last two categories, the missed and misinterpreted, represent almost 50% of the interval cancers. This is also why interval cancers are a quality measure for screening programs. The lower the interval cancer rate, the better the performance. So, how can we reduce them within the existing screening programs? As I said before, at present, all European breast cancer screening programs are based on 2D FFDM, and DBT is only used in trials like the RETOMO trial from Emilia-Romagna, the TOBI trial from Norway, or the TOSIMA trial from Germany. Now, what did we do? Actually, we looked at women with known interval cancers from our unit who had normal screening exams in 2011 and 2012, and where diagnostic images at tumor detection were available together with full clinical records. What we did is, for quality assurance, these cancers are reported to us by the Regional Cancer Registry, and then we have to categorize them in 4 categories: true interval cancers, occult interval cancers, minimal sign interval cancers, and missed interval cancers based on the findings or non-findings in the priors. We then processed the priors through the algorithm, which was Profound AI by ICAT, and reread them considering a mark with a lesion score higher than 30 as a positive finding. A lesion score is a score that the algorithm assigns to a lesion, which gives a probability that this lesion might be a cancer. Our results were as follows. 48% of all interval cancers that were labeled as normals in 2011 and 2012 on the priors had lesions marked at the location of the later detected tumor. And 93% of the minimal sign and missed interval cancers had lesions marked at the location where the tumor was later detected. There are some weaknesses of this study, of course. The numbers of interval cancers are fortunately low. Therefore, it gives rather a view on the direction than on the true percentage of the decrease of interval cancer rate. And secondly, the specificity of the algorithm can only be estimated based on another study, which was performed in the Reference Center of Munich by Professor Haiwan Köbrunner with the same algorithm. In other words, if Profound AI had been available and used in 2011 and 2012, up to optimally 48% of the later detected cancers in the interval could have been found in the initial screening round, especially the missed and the minimal sign ones. Profound AI has the potential to help the radiologists decrease the interval cancer rate and therefore improve the quality of the screening program, resulting in a better care for women. We published this as a research letter because we have some recommendations. What we would need are prospective randomized controlled trials using an AI algorithm as a supportive tool within a screening program. Outcomes should be sensitivity or detection, specificity and false positives, and the interval cancer rate, of course. I would like to show you some examples of our study. This is a screening exam which was determined as normal by 2 readers. After 10 months, the woman came back with a palpable mass, and what you can see is actually a retraction of the skin and a skin thickening, and also a mass with small calcifications. Biopsy revealed it was 0.9 centimeter NST, G1, no lymph nodes, and no distant metastasis. Going back to the initial screening images and running the algorithm on that, we can see that the algorithm detected a lesion with a probability or a lesion score of 72% to be a cancer. We considered this a reader miss due to minimal sign. The second case is quite similar. Again, the screening exam was determined as normal by 2 readers. And 9 months later, a diagnostic mammography was performed because of a palpable mass. And what you can see is cancer in the right breast of 2.5 centimeter in diameter. It was invasive lobular cancer, G2, no lymph nodes, and no distant metastasis. Again, we ran the algorithm on the images, and it showed us a detection in the location where later the tumor occurred or where later the tumor was found, with a probability of 58% to be a cancer. We considered this a missed cancer. The third example also was determined as normal in the initial screening round by the readers, by 2 readers. The images, the diagnostic images after 14 months show lesion. It was a palpable mass, and histopathology after biopsy revealed it was a 1.6 centimeter NST, G1, no lymph nodes, no distant metastasis. And again, retrospectively applied the algorithm, found a lesion on the left side, especially in the OBL view. You can see it has a lesion score of 97%. This was, again, a missed cancer. All these cancers could have been avoided if we would have used or could have used the algorithm at that time. Now, the second study is a retrospective comparison between single reading plus an artificial intelligence algorithm and 2-view tomosynthesis with the standard of care double reading in breast screening. What was the idea for this study? We have some existing recommendations from the European guidelines. Since last summer, the European guidelines recommend to use as the standard screening examination either 2D FFDM or DBT. And double reading is always recommended over single reading. The problem is do we have enough human resources to read tomosynthesis if the program switches to tomosynthesis instead of 2D FFDM? Is it possible to have at least the high quality of the existing 2D FFDM screening programs, maybe by having single reading tomosynthesis supported by AI? So we looked at a population of women in our screening unit with a biopsy-proven cancer from the National Screening Program, which had 2D FFDM in screening as the primary method and additional DBT in assessment. We did reread the tomosynthesis, or an experienced reader reread the tomosynthesis images supported by Profound AI, a deep learning algorithm developed by ICAD Nashua USA. This is a different algorithm because it looks at 3D imaging. And the results were reading results of the single reader of tomosynthesis with AI had the same reading results compared to double reading of the 2D FFGM. Reading results of single reading of Tomo with AI outperformed single readers of 2D FFDM significantly in sensitivity. The overall result was that single reading of tomosynthesis with support of a suitable algorithm is not inferior to the double reading policy of today's screening programs with 2D FFDM regarding sensitivity. Of course, again, there are some weaknesses of this study. One is numbers, but also we couldn't say anything about DCIS because at that time calcs were assessed with magnification views rather than DBT. And the specificity of the reading process with AI couldn't be assessed, but there are some studies that used the same algorithm which demonstrated a high specificity. Especially Emily Conant did a publication in Radiology in 2019. Well, in other words, if we could screen from today with DBT, with a single reader supported by an artificial intelligence algorithm, we would certainly not detect less cancers. In fact, as we all know that DBT has the capability to detect more cancers, it is very likely to detect more cancers using the above named policy. It would probably improve even more if we did double reading of tomosynthesis with AI, especially for specificity reasons. Again, this was published as a research letter, and following that, there are some recommendations. What we would need is a prospective randomized controlled trial on reading tomosynthesis supported by an AI algorithm within a running screening program. Outcomes should be detection or sensitivity, false positives or specificity, interval cancers, but also reading time and cost effectiveness, because in her study, Emily Conant also said that reading time for tomosynthesis can be cut in half. I will show you how the system works in an example. What you see is a 2D synthesized view of tomosynthesis, and when you see this, you can see a mark, a small mark in the right breast. I put the cursor here, and if you click on that mark, the system or the algorithm lets you jump right into the plane where you see the lesion that is marked best on tomosynthesis. So that's very quick. And I enhanced that or magnified that a little bit. It showed a mass which is spiculated. This revealed to be an IDC associated with the DCIS, T1C, no lymph nodes, no distant metastasis, and it was G2. Now I show you some images from our study. For convenience reasons, I only put up the 2D synthesized. This lesion or this cancer was detected only by one reader in the initial screening and only detected in the CC view. It's a small lesion up here in the lateral part of the breast. And when you look at the tomosynthesis, it shows you a mark, and this mark had a 73% lesion score, which shows you that it has a high probability to be a cancer. What really astonished us is that the algorithm also found the lesion at the OBL view with the same confidence. This is another example of a screening exam. I show you the synthesized tomosynthesis images again, and the algorithm showed us a mark in the upper part of the right breast, and when you go to the plane, it shows you this mark or this encircled lesion has a probability of 69% to be a cancer. It's a small stellate lesion, and histopathology revealed it was an NST of 0.8 centimeters in diameter, G1, no lymph nodes, no distant metastasis. I show you the same case in the CC view. Again, you see the marker here in the 2D synthesized, and when you jump into the plane, it gives you even an 85% probability for this to be a cancer. Well, what are the conclusions of these studies or little research projects? Reading to the FFDM supported by Profound AI will reduce the number of interval cancers by guiding the radiologists to regions of interest that he or she might miss in the process of reading, thus avoiding interval cancers. Reading tomosynthesis as a single reader supported by Profound AI will not give inferior results sensitivity-wise to standard double reading of 2D images. In fact, it is most likely to detect more cancers. Double reading tomosynthesis with support of Profound AI might be even more efficient, especially in increasing specificity. But further studies, preferably randomized controlled trials and screening programs, are needed to address outcomes such as sensitivity, specificity, recall rates, and interval cancer rates in real life. I would like to thank you for listening. Also, I would like to thank you for GE supporting me in this presentation, and also for many years of good collaboration with all their devices. We do all imaging on GE Senograph Essentials at the moment, and we read on the Seno Iris. And also I would like to thank ICAT for giving us the chance to do some research with their products. Thank you very much.
Dr. Greenwald, thank you very much for your excellent and very informative presentation. I do have one question for you.
Yes.
Do you think that artificial intelligence, DBT screening, can replace full-field digital mammography screening?
I do believe it will replace it. Maybe not for all women, but maybe for a certain subgroup, like women with very dense breasts. But I do think that's the way it's going, because we know that detection rates are much higher with DBT. The problem always is the so-called overdiagnosis or a decreasing specificity, maybe.
Thank you very much.
Okay.
Now we're going to the next presentation, which is clinical effectiveness of artificial intelligence application on 3D tomosynthesis and 2D full-field mammography case presentation. There will be two speakers, Dr. Ioannidou and Dr. Dimitropoulos. Both of them are consultant radiologists, co-owners of private center in Athens, and members of the board of directors of Hellenic Breast Radiologists. Dr. Dimitropoulos, I'm passing on the microphone to you.
So it's me who will start. Good morning. In the next few minutes, we will review some screening and diagnostic cases and point out the importance of artificial intelligence in breast tomosynthesis. This is our first case. It's a lady of 72-year-old. In the FFDM, some small round opacities are apparent in both breasts. In the retromammary part of the left breast, a small round nodule having mild contour irregularity has been detected by both readers, who asked for a further DBT of the left breast. The DBT confirmed the presence and the morphology of the nodule in the outer part of the left breast, and the AI evaluated it with a high lesion score. The ultrasound depicted this round nodule with mildly indistinct borders and a thick surrounding echogenic rim, and biopsy found the 0.6 centimeter breast cancer NST of grade 1. And the AI contribution in this case, it recognizes the non-benign signs on a very small nodule, increasing diagnostic confidence for the readers. Next case is a 52-year-old woman with a dense breast. This is last year's examination. One of the readers has detected a difference in the upper part of the left breast and asked for a further DPT. The DPT showed an architectural distortion in the upper part of the left breast that was detected by both readers, but only in the MLO position, while the lesion was not detected on the CC DPT. The AI algorithm detected the lesion both in the MLO and in the CC projections and evaluated it with a high lesion score. The ultrasound depicted this solid nodule with irregular borders, and histopathology revealed a 1 centimeter breast cancer NST of grade 2. And the AI contribution in this case, it correctly detected the exact position of the lesion, which was quite difficult for the readers due to the density of the breast parenchyma. Next case is a 73-year-old woman. Doctor referred to us for a palpable lump of the left breast. Both FFTM and DPT were performed. In the FFTM, no lesion was detected by the readers. On the DPT of the left breast, both readers detected an architectural distortion in the upper part of the breast, while the AI algorithm detected 2 lesions in the same part of the breast as architectural distortions and evaluated lesion A with a high score and lesion B with a low score. The ultrasound depicted at the 2 o'clock position of the left breast these 2 solid nodules with irregular borders, and histopathology revealed 2 foci of breast cancer NST of grade 3. And the AI contribution, it finds out additional foci enabling better patient management. Next case is a 42-year-old woman, self-referred to us for a DPT opportunistic screening due to intermediate risk. A fairly dense breast. In the DPT, both readers detected 2 nodules, one on the right breast and another one on the lower part of the left breast, as we can see here. The AI detected both lesions and evaluated the lesion of the right breast with a low score and the lesion of the left breast with a high score. On the right breast, there was no difference from previous year's examinations, while on the left breast, in correlation with last year's examination, we saw an increase in the size of the nodule. The focused ultrasound depicted at the 4 o'clock position of the left breast this round solid nodule, having 2 spiculae on the contour, and histopathology revealed a 0.8 centimeter medullary breast carcinoma. And the AI contribution was the differentiation between 2 similar lesions and the detection of the non-benign nodule. In this last case, a woman of 84 years, doctor referred to us for an FFTM and a DPT due to palpable lump of the 12 o'clock position of the left breast. This is a rather fatty breast. On the DPT of the left breast, this big spiculated mass was detected by both readers as a Byratt's 5 finding, whereas on the right breast, no further lesions were detected by the readers. The AI evaluated the lesion of the left breast with a very high score, but the algorithm detected another lesion on the lower part of the right breast, which was missed by the readers, probably due to attraction of the attention by the lesion of the left breast. This was an area of microcalcifications, and going back to the DBT of the right breast, we can identify this lesion on the lower part of the breast, as we can see here. Histopathology revealed on the left breast a 2.8 centimeter breast cancer NST of grade 2 with axillary lymph nodes, and on the right breast a 0.5 centimeter DCIS of intermediate grade. And the AI contribution, it detected and evaluated additional foci on the contralateral breast. And at this point, I would like to thank you very much and hand over to Dr. Dimitropoulos for some more cases.
I will present you the performance of AI FFTM in 6 cases in opportunistic screening. I have no disclosures. First 3 cases with lesions difficult to detect and evaluate. Case number 1, woman's age 57 with average risk. Density category 3, readers have detected no lesion. This is a correlation to previous exams. Readers detected no difference. AI has detected a nodule in the left breast with a lesion score of 49%, case score 63%. In retrospective evaluation of the area indicated by AI, the image of the left breast has changed from the previous year's exams. In this area, focus ultrasound was suggested. In nodules with a lesion score over 30%, we perform a focus ultrasound in the area indicated by AI. Focus ultrasound in the 2 o'clock position of the left breast has detected a lobulated nodule, Byratt's 4A. Guided core biopsy was performed, and histopathology was 1 centimeter breast cancer NST G2 and 0M0. This is case number 2, age 41 with average risk, density category 3. Both readers have detected in the right breast a cluster of microcalcifications of no special type, Byratt's 3, suggesting repeat mammography of the right breast in 6 months. AI has detected a lesion with a lesion score of 42% and case score 55%. Of course, biopsy evaluation has changed from 3 to 4A, and biopsy was decided. But before stereotactic biopsy, ultrasound was performed to investigate the possible presence of a mass. This is the focus ultrasound. There was a solid nodule detected with irregular borders and calcifications by RH4B. Guided biopsy by ultrasound was performed, and histopathology detected 0.8 centimeters DCIS intermediate grade and 0.6 breast cancer in stage G2. This is case number 3. Woman age 41, elevated risk due to mother's history of breast cancer. Density category 3, one reader detected an asymmetric density with architectural distortion on the left breast. This is last year's mammography, and of course there's a difference in the left breast from last year in this area. AI detects the lesion, increasing diagnostic confidence. With a lesion score 42%, case score 55%, focus ultrasound was performed, and an area with architectural distortion in the left breast 10 o'clock position was detected, RH4A. Guided core biopsy was performed by ultrasound, and histopathology 2.4 centimeter infiltrating lobular carcinoma. And now 3 cases with lesions almost invisible, having minimal signs. Case number 4, woman age 51 with average risk, dense breasts. She's reporting fibroadenoma since the young age. Both radiologists have detected benign findings in the left breast. Correlation to previous, no difference from last year. AI has detected the fibroadenomas in the left breast here, but an area of architectural distortion in the central part of the right breast. Architectural distortion was detected and characterized as BIRAS4A, lesion score 35%, case score 45%. Difficult to detect the lesion due to minimal signs. This is the area. This is the area of architectural distortion. Need for focused ultrasound exam. And in focused ultrasound of the right breast, there was an irregular mass, BIRAS4C, and of course fibroadenomas in the left breast. And guided biopsy was performed. Histopathology of the right breast, 1.4 centimeters NST, G2 and 0M0. Case number 5, woman age 68, average risk, dense category 2, both readers detected no lesion. AI has detected a cluster of fine macrocalcification in the left breast. This is a magnification view of the cluster. Lesion score 61%, case score 81%, BIRAS4A. Biopsy was performed, and stereotactic biopsy revealed ADH, and surgical biopsy that followed ADH plus a focus 2 millimeters DCIS intermediate grade. And case number 6, woman age 66 with average risk, dense category 1, detected by 2 readers around nodule of the left breast with partially irregular borders by RH4B. AI detects the lesion with a lesion score 90%, case score 95%, of course focus ultrasound, a solid nodule with irregular borders by RH4B, and ultrasound guided core biopsy showed 0.7 NST G2 and 0 M0. But let's have a look at the situation in last year. This is retrospective FFDM evaluation of the last year. Soft round nodule seen only in a left MLO view was not evaluated by readers, but detected by AI retrospectively. Lesion score 70%, case score 91%. And in all 6 cases, AI has saved critical time for patients changing BIRATS evaluation and detecting cancers with minimal signs before radiologists. Thank you. Professor Giatas.
Dr. Dimitropoulos and Dr. Ioannidou, excellent presentations. I do have one question for Dr. Dimitropoulos. Do you think that AI algorithm is good enough to replace the second reader in full-field digital mammography screening program?
AI is an additional reading tool for the radiologist, even his experience or not. It could replace the second reader in a screening program while maintaining, of course, the human consensus reading. It has the potential to reduce the interval cancer rate through pointing out lesions to the reader for further evaluation, but it could have a negative effect on recall rate, and this is a challenge for future research. Further studies are needed on screening population and different algorithms, because we have different algorithms, in order to assess the accuracy of AI algorithms, and randomized trials to confirm the impact of introducing AI algorithms in organized quality assured screening program.
Thank you very much.
I thank you. And now we continue with the program. We come to the risk assessment. All women do not have the same risk for developing breast cancer in their lives. There are many ways to assess the risk. Different risk levels lead to different screening strategies. This is personalization, and next presentation will be breast cancer risk stratification and personalized screening by Professor Mitrakakis, who is a professor of gynecology in the Athens University, breast surgeon, chief of the breast unit in University Alexandra Hospital, Athens. Professor Mitrakakis.
Good morning to everybody. You see, I'm not a radiologist, but I have a mammogram in my background. I'm going to share the screen. First of all, I would like to thank the president and the organizer of this innovative meeting, Dr. Dimitropoulos. And I'm glad I'll give a talk today in a difficult topic: breast cancer risk stratification and personalized screening. Okay. Breast cancer, as we all know, is a common disease. There is little to do for prevention, and the best defense we have against cancer is the early detection. And early detection has been proven by big randomized trials to increase survival. However, in these big randomized trials, the only inclusion criteria of the woman to screen was the age. But we know that there are women with increased risk for developing breast cancer, and there are some other women who have a reduced risk for developing breast cancer. So who is at increased risk for developing breast cancer? Those women who have a known BRCA1 or 2 gene mutation, or some other mutations like in Li-Fraumeni syndrome, Cowden's disease, etc., or who have a first-degree relative with one of these mutations. When a woman has a risk higher with more than one affected first-degree relatives, and the risk is higher when the relative was diagnosed at a young age, and as many relatives we have, the risk increases. Also at decreased risk are women who have a lifetime risk of breast cancer more than 20%, according to risk assessment tools. I'll talk later about these tools that are based mainly on family history. Those women who had the radiation therapy to the chest between the ages of 10 and 30, and those who in a biopsy developed atypia, LCIS, DCIS, invasive breast cancer or invasive ovarian cancer. This is according to the American Cancer Society and the American College of Radiologists, and a little bit the same with the NCCN. So we need a personalized screening to these women who have a higher risk for developing breast cancer. And this augmenting screen has the meaning to start the screen earlier, before the age of 40, mainly with mammogram and additionally supplementary MRI or ultrasound. In that way, the personalized screening seems to be an attractive evolution, given that the main purpose is the tailored surveillance of these women in high risk, and not to reduce screening in low or moderate risk by cutting costs, etc. This is a schematic prevention of a personalized approach to early detection and prevention of breast cancer according to Nature reviews. You see that they stratify women to 4 groups. Those with low or moderate risk, where reduced intensity screening or no screening could be applied. Those who belong to the high risk group, where we need an intensified screening, and those in a very high risk group, where we should apply prophylactic treatment, surgical or medical. And what about the intensified screening? What should be the intensified screening intervention? It depends on the category each woman belongs. For example, a woman with BRCA1 or 2 mutations or first degree relative with such mutations, we need or lifetime risk more than 20% according to risk stratification models. We need a yearly mammogram plus MRI from the age of 40. Those women who had the radiation therapy to the chest, yearly mammogram plus MRI 8 years after radiation. In women with atypia, LCIS, DCIS, invasive breast or ovarian cancer, yearly mammogram, and from the time of diagnosis, and here MRI is questionable. Yearly, annual MRI is questionable. And what about complementary ultrasound? We should apply ultrasound in women with dense breast, in women with risk, not very high risk, more than 20%, but between 15 to 20%, where annual MRI is not necessarily recommended. And also in women with high risk, in high risk, more than 20%, where MRI cannot be performed. What about risk calculator models? There are several models. The most used, the most popular is the Gale model that incorporates 6 risk factors. The closed model, which contains a more detailed family history. It's better when we have a rich family history of breast cancers. The BRCA Pro model, it's good to estimate the likelihood of BRCA1 or 2 mutations for testing, but it does not include biopsies, atypia, etc. So it seems to underestimate risk. And the Tiered-Cusick model may be the most comprehensive that produces higher, more accurate estimates. The last 3 models are good in determining whether MRI is an effective screening tool. This is the Breast Cancer Surveillance Consortium Risk Calculator model, which is the most recent version of Gale model available in the internet. And it gives the estimation of 5-10 years breast cancer risk based on these 5 factors. And you see that it incorporates breast density. However, this calculator that is used widely today, and it's available in the internet, is not applicable to women that are very young or very old, that have a previous diagnosis of invasive breast or cancer or DCIS, of previous breast augmentation or previous mastectomy. There are also some other models in the internet, not for women, not for health professionals, but for women. And some of them, they propose actions to keep a moderate risk in the screening program. There is also a new proposal last February to stratify for screening women of average risk on the basis of a single evaluation of breast density at the age of 40. You see that there is no perfect risk stratification model. Breast density is not a major risk factor, and many researchers believe that the effect of breast density on masking is greater than the effect on risk. Also, we should have in mind that most women with breast cancer are not at elevated risk. That means that they have no measure of the known risk factors today. So there is a need for new risk factors as single nucleotide polymorphisms, SNPs, that are genetic variants and can be used alone or in combination for stratification. But however, today there is sufficient data to use for stratification these SNPs alone. It's also the radiomics that are clinical images based on structural features, and we can use it for stratifications. and also the deep learning machine applications or artificial intelligence applications that they can combine data and improve risk assessment. And you see that the risk assessment is continually evolving. This is an overview, according to Nature Medicine, of personalized risk reduction and breast cancer prevention paradigms. You see that there are various risk factors that contribute to field defects in breast tissues that favor the development of breast cancer. Such field defects can be assessed using biomarkers or imaging. And these biomarkers and imaging can guide personalized prevention strategies, and the success of the strategies can be monitored by intermediate surrogates. And these intermediate surrogates reflect the ultimate goal, that is the decreased incidence of breast cancers with features indicative of poor prognosis. You see that the risk stratified early detection and prevention is not a simple thing. It's a complex system. There are many questions to be answered. Which factors to include in risk assessments? What should be the cutoff level for stratification? How many risk groups to have? When to do risk assessment? How often to screen and whom? Which interventions should be used in individuals at high risk? And you see that the decision-making is influenced by research, by available resources, healthcare settings, and societal values and norms. And the program of stratification of risks and the applied personalized screening should be effective. The benefit harm ratio or the cost benefit ratio should be high. They should be effective, acceptable, accessible, and feasible to implement. And you see that there are dynamic interactions between each of these factors. If you change one factor, you change the whole system. That's the important, makes the importance of a holistic approach. That's why the Vision, a European collaborative, is organizing a wide program to use existing research data in order to develop evidence-based personalized interventions. And that's why there are two randomized clinical trials now, one in Europe, MyPEBS, personalized breast screening, and one similar in the United States, the Wisdom. They try to assess the effectiveness and feasibility of personalized breast cancer screening, and they will include, MyPEBS will include 85,000 women from the European countries. So soon, we hope we will have results of these two big randomized trials. And up to that time, the conclusions are that there is some evidence of the effectiveness of screening personalizations in terms of quality-adjusted life years. It's not only the survival to extend the years of life, but the quality years. So that's why we measure today the quality-adjusted life years and the cost-effectiveness ratio. And we're based in modeling studies and observational studies up to now. However, evidence is lacking on feasibility and acceptance by target population. We need new risk factors, and we always should have in mind that the purpose of risk assessment is to provide supplemental screening to high risk and not to reduce it in average risk women. Thank you.
We thank you. We thank you, Kostas, for your excellent presentation on a very difficult topic. But I think this is the future, and we have to look towards the future. One question. Do you think that cancers that occur in high-risk population have a special biological behavior, so we have to behave different to those cancers?
Yeah, that's a difficult question. That's a question of 1 million. I'm afraid there is no clear answer to this question. And I would say that I was a little bit disappointed when I was studying the literature to make this presentation, because I couldn't find any serious, any big study to answer this question. The thing is that the target of this personalized screening, the risk stratification and the personalized screening, is to detect early onset of breast cancers. Early onset means in younger ages, and a cancer who develops in young age is by definition of a cancer of poor prognosis. It's more related to gene mutations. It's more, the histological type is more common triple negative or overexpressing HER2. And generally, it's a cancer of poor prognosis. So by the time that these two big randomized clinical trials, MyPEBS and Wisdom United States, will answer in a way your question, were based in observational and retrospective studies, and on the basis that early onset of breast cancer is a cancer of mainly bad prognosis.
Thank you. Thank you, Kostas. And now something really innovative. Can a simple FFDM image contain data to assess a woman's risk for developing breast cancer? Next presentation will be Profound AI Risk for 2-year breast cancer risk stratification, and the presenter is Professor Per Hall. Per Hall is a pioneer in this project. He is a professor of medical epidemiology in Karolinska Institute, Stockholm, member of the study team in Karma Risk Assessment Study, and co-author in a large number of studies concerning breast cancer risk. Professor Hall.
Thank you very much. Thank you very much for inviting me to what seems to be a really exciting meeting. It's just started this morning. And also thank you for the previous speaker who gave the big picture when it comes to risk assessment, and I will give a little smaller picture, or at least I will describe what we do. So my name is Per Hall. I'm a medical oncologist by training, so I am not a radiologist. I'm also an epidemiologist. So for the past 20 years, I've been doing mainly breast cancer epidemiology. We start off with an image here. So firstly, I describe what's happening in Sweden. So we have mammography screening programs started in the 80s. We screen all women between 40 and 74 every second year. And when I try to describe what would be the purpose of risk-based screening to lay people, not to you, because you know all about this, but to lay people, I give them the 4 BI-RADS categories, A, B, C, D. And then I tell politicians and people with power that today we screen these women in exactly the same way, despite the fact that women who have a really very low density has a low risk compared to women with a high density. So if we use this as a reference, you of course know that these women have 5-6 times the risk. This is, by the way, our own data from the Karma Cohort. But this is not the only reason why we should reflect on risk-based screening. It's also the sensitivity, and you know all about this, high sensitivity in BI-RADS A and the not too good sensitivity in BI-RADS D. So this is what I forward. So what we have done over the years is that we recently published this paper by Mikael Eriksson, who is a former PhD student, now is a postdoc in my group, and these are a lot of radiologists from Sweden and some geneticists as well. This was published in November last year. The aim of the model was to answer the question, who are the women that will be diagnosed with a breast cancer within 2 years after being sent home with a negative mammogram? So who are the women that will be diagnosed with interval cancer or a cancer at the next screen? That was a simple question, because we had looked into the models, risk models that was presented in the last presentation, and they are not really fit for this question. They're not really fit for changing mammography screening. And I will talk a little bit about that. Firstly, I just present our data sets. We have something called the Karma Cohort that was mentioned. So we invited women between 2011 and 13 from 4 hospitals in Sweden. Approximately 70,000 women participated. We collect mammograms, and we collect an enormous amount of things, DNA, plasma. 25,000 have been genotyped. We have access to tumors and so forth. So and here you have the homepage. And why do I show you this? Not only to brag, but also to tell you that we are willing to share data with fellow researchers. So we have so far, over these 10 years, shared data more than up to 500 times. So if ethics is on your side, we are definitely willing to share everything from DNA to images. Anyway, this data set was used in the radiology paper. So we followed women who were included in 2011 to 13 for a couple of years. 974 women were diagnosed with cancer, and we took a subset of the cohort because we couldn't afford to genotype the entire cohort. So what we did was a case cohort analysis, genotyped using something called the Illumina array. And then we took the last prior negative mammogram for cases, and the interval between the last examination and cancer was 1.2 years. So this is the background for the paper. So little comment on the other risk models that was mentioned previously in the previous very good presentation. So this was a paper 2 years ago, and here are the different risk models. And there's a number of papers out there. So they compare the models, the discrimination, and that's the ability to tell who will be diagnosed with breast cancer, who will not, the calibration, how well does it really reflect what is happening in true life. And then in this case, use a 10-year risk model. But what I lacked in this paper and most other papers is, shouldn't you start off by asking yourself, what should a model be used for? Should it be used for prevention? Should it be used for risk-based screening? If it's going to be used for prevention, then yeah, maybe a 10-year or a lifetime model could be used. But if it's risk-based screening, should you really have a 10-year risk model? That's not what we think. And further, as also mentioned previously, if the model is going to be used for changing screening, you have to include mammographic density. And IBs or Tyre-Cuzick use that, and now it's been added to the others. What is here model has now adding it, and we are helping out. But mostly very simple way. They just use the BI-RAD score. So let me tell you a little bit about the 2-year risk model that we have developed in collaboration with ICAD. So what we have done is that we have, as indicated, we have used, this is 3-stage models. You could say it's model 1, 2, 3, so I will tell you all about that. The first model, we use age, use mammographic density, we use the asymmetry between left and right breast, use calcification masses. And here we had used machine learning to train our program. You know, we had, as in the Karma data set, we have so many mammograms. By now we have 3.5 million mammograms, so we could compare the easier to measure density in raw images than in processed images. But we have now solved the problem, so density could be measured automatically, regardless if it's GE, Siemens, Philips, whatever it is, that works out. Classifications of masses, that was in collaboration with ICAD, so they very openly shared the script a couple of years ago, and since a couple of years back, we're now collaborating, and I receive part of a salary of one of the employees are paid by ICAD, so that should be revealed. But this is, remember now, the first model. It's age and mammographic features, we call them, density, calcifications, and masses, and the asymmetry between left and right. The second model, we add BMI, menopausal status, family history, hormone replacement therapy, alcohol, and tobacco. And then the third model, firstly, I should say that the interesting thing here is that we need so few of these lifestyle factors compared to the other risk models. And why is this? This is because we so heavily depend on the density. So very many of the lifestyle factors are reflected in density. So if you have very many children, your first child very early in life, you're breastfeeding, then your density will definitely go down. So factors like that doesn't add to our model, but these factors did. So that was model 2. So model 2 consists of model 1 plus model 2. And then model 3, then we take 1, 2, and 3, and a polygenic risk score, the latest published by the Cambridge group 2 years ago. There's constant updates, but this is what we say. So you take, as mentioned, the single nucleotide polymorphism, one little alteration in the genome, doesn't really tell you much, but if you put them all together, you get something called a polygenic risk score, and then it really adds, and I will show you that. So now look into what we have here. This is the AUC, you know all about that. So model 1, only using the mammographic features, we reach an AUC of 0.73. Adding the lifestyle factors and family history and so forth is a very little minute improvement. The PRS, yes, definitely so, and I will see you where it actually influences. We managed to validate this model 1 in 3 independent data sets, one of them our own, but also 2 other Swedish data sets. So that was reassuring. Unfortunately, we couldn't validate model 3 because there are no other data sets with both genetics and density or mammograms, access to mammograms. Compared to Tyre-Cuzick and the mammographic density and Gale and mammographic density, you see that the AUCs are quite substantially lower. This is a huge difference between 0.73 and 0.62. Okay, so what happened when we stratified women? So what we did, remember this is a 2-year risk, what we did was we took the 10-year risk, the NICE guidelines, the UK NICE guidelines, divided them by 5, and we got what we could use for 2-year risk. And here you have model 1. You see that in the low risk group, there are 4%, in the general, the average 60 and so forth. No big difference when you add on the lifestyle factors. The huge difference is when you add on the polygenic risk score. Then you, for the first time, are really able to identify the low risk group, because what the polygenic risk score is doing is that it really adds to the tails of the risk. If we assume bell-shaped curve, it adds to the tails. So if we take the model 3, look at this here, and what happens then? What does it actually? So this is how we stratify them. But what is the absolute risk and the relative risk? If we start with absolute 2-year risks, this should be interpreted 0.09% of women will be diagnosed with breast cancer over the coming 2 years. So that's 1 woman in 1,000 will be diagnosed with breast cancer, which is a low risk. And here you have 2.7%, which means that 1 woman in 35, 40 approximately will be diagnosed with breast cancer over the coming 2 years. In relative matters, if you use the general as a reference, you could see that these 8% of women have a 9-fold increased risk compared to the general, and here's a third of the risk. So this is better. And if we compare to the previous models, they have great difficulty in identifying the high risk women. Normally, the high risk consists of 2-3%. And then, of course, comes the questions: what are we going to do with the women? But that's outside my presentation. Even though we are thinking of low dose tamoxifen, we published 2 days ago on a paper showing that maybe we could use 2.5 milligrams of tamoxifen instead of 20 milligrams, but that's outside the scope. So let's see how we think about risk prediction and risk assessment should be done. So this is a Swedish setting. We screen every 2nd year. This is a lifespan. This is initial screen. What's very often now discussed, for instance, in the Lancet paper, is that you measure the 10-year risk and then you adopt your screening according to that. And it could be 3D, or it could be tomosynthesis for women with dense breast, or ultrasound or MRI or whatever. Maybe that's not the most efficient way. So the way we look at it is instead to do the repeat risk assessment at each screen, because risk, as everything in life, changes. For a risk model like ours, or most models, family history changes, density changes, calcifications. All radiologists know about that, and it increases a couple of years before a diagnosis. Asymmetry between left and right breast. So all these things changes. That's why we believe this is the only way to do risk assessment if you want to change from age-based to risk-based screening. And this is where we end up, and we are now thinking of we are planning a study, but it's really difficult to get it funded, where we would like to screen these women as always, just continue every second year. For these women, 25% approximately, they should have some kind of intensified screening if they have dense breasts, because not all of these women have dense breasts. You have women in this group who have sky high risk of breast cancer, but they have BI-RADS A or B. And then they have a high risk because they have calcifications that are asymmetrically distributed between right and left breast, and they have a family history. So it's not as simple as high density, high risk, low density, low risk, but you know this. Then, of course, we've also been thinking about, is it so that a snapshot in time, only one mammogram should only one mammogram be used for determining the risk? We know that density goes down. This is again Karma data. Here you have age. Here you have percent density. Here you see it goes down, and percent density is of course influenced by BMI. Percent density, that's the percent of the breast that is dense, and if you have low BMI, you have smaller breasts, and therefore the percent density goes up. So this is how we thought. Couldn't it be so that women who stay dense, these are the women that are more likely to be diagnosed with breast cancer? So last year, another student of mine, Shadia Assam, published a study in the NCI, and we were so convinced that if you decrease in density, you would have a lower risk, but we couldn't show anything of this. We found no difference in breast cancer risk, which I assume to radiologists is counterintuitive. But if you think about it, women who decrease in density, their sensitivity goes up. So it's more likely that you detect the cancer in this group than in this group. So these two forces probably evens out. And what we are dealing with now is that we are thinking, this is the distribution in density. You have small figures here, 40, 50, 60, 70, 80 is the density again. And here the blue line are the cases, and these are the controls. And you can see that there's a difference in density between case and controls, nothing new. Nothing new, that is a smaller difference in possible women. But the way we look at it now, maybe we should look, instead of having this snapshot, one single mammogram, we should look into the cumulative density over a longer period. And I assume that that is something that radiologists do intuitively. I mean, you always compare to previous images. You compare, was this lesion there before? Was the calcifications there? Has the density changed? So it could be that cumulative density, if you take a mammogram here, looking back, has this woman been very dense over a lifetime, then she has a higher risk, which is more important than just that measure. Okay, that was slightly outside. So this was my presentation. And the conclusions are that the profound AI risk is a 2-year risk model developed to be used for risk-based breast cancer screening. In its simplest version, that's also only taking mammographic features into consideration. It outperforms all other current risk models, and it's also it has the beauty of it because it's simple, because it's easy to handle. You install a program, and all you need is to know the age of the women, which you all know, and to have access to the mammograms. And then you could calculate. You don't have to ask about family history. You don't have to ask about alcohol. You don't have to ask about kids, hormone replacement therapy. And it also, so when I talk to radiologists, they like the model because we use the features that you already use when you do your clinical workup. And as I said, the model outperforms current risk models as IQs and Gale. The weakness is, of course, that we have developed it in a Swedish setting, we have validated in the Swedish data set, and we are now in collaboration with Axel Grevelholt to do the first presentation, and with the people at ICAD validating the model in the European and US data sets. Thank you very much. That was all. Oh, I should also thank, of course, sorry. Last slide. These are all the people involved at the South General Hospital, Syracuse. This is the Karma group, and this is people that we work with at the University of Lund. Yeah, now I'm finished.
Thank you, Professor Hall. for your really very interesting, impressive presentation. And of course, questions are coming where we are used in lifetime risk. And what is the correlation of the levels, the risk levels of 2-year risk to the known to us 10 lifetime risk levels? And
Yeah.
do you have any idea of what to do concerning to your scores, to your what do we have to do as radiologists and to advise women in those scores, the new ones, and what is the role of the radiologist in this risk-based screening, let's say, for the future?
So firstly, the first question, how does it compare to 5-10, the lifetime risk model? That's a really good question, and we can't really tell. So what we're working on right now, because we have the sufficient follow-up. So I would like to answer that question to you in a couple of months' time when we have our 5-year risk model, and then I will back to you. When it comes to what we should do, it's up to each situation, the routines, the culture, how you deal with this. But the way we're thinking now is that we have approximately 25% of the women who have a low risk, 50% who have a intermediate risk or average risk, and then you have 25% at high risk. For low risk women, we could start thinking about, should it be that AI replaces one of the readers, maybe not both readers? Should it be that the low risk women should come, in Sweden we have every 2nd year, should be every 4th year. For the average, I just think that we should continue as we do now. For the high risk group, for those who have high risk with no increased density, I would suggest to have more frequent ordinary mammograms. You don't need any fancy MRIs or anything like that. For high risk with high density, what we're thinking of and want to test now is contrast enhanced mammography. It's quick, it's comparatively cheap, and it seems to be nearly as good as MRI, even though we don't know that. For the women at really high risk, I don't think it's sufficient just to say that we will screen you more often or supplemental screening. I think we also have to start thinking about prevention in these cases.
And of course, a different role for the radiologists.
A different role for the radiologist, but you are constantly expanding. Radiology, I mean, when I started medicine, that was very many years ago, radiology was I actually worked as a radiologist for half a year. It was quite a passive thing. You looked at your white and black images, but now there's far more into radiology. So I think that the radiologist would be the center. When you discuss with the center risk assessment and risk-based screening, when you talk about to colleagues and you meet them at seminars and so forth, they say, should this be risk counselors? Should this be specially trained nurses? I think still the radiologist will be the key persons. And they, in the US, as you know, they have taken on a more and more active role in screening. And then I talked to US radiologists. They didn't only use mammograms to screen for breast cancer and identify high risk. They also identify risk of cardiovascular disorder dependent on the microcalcification. So they sent women off to counseling for cardiac disorders as well. If that's the future, I don't know.
So thank you. We will follow your studies, and I hope we'll have the chance to have here with you again in the near future. Thank you
very much. Thank you for having me.
And now a short video will be presented showing an interesting clinical case on the use of profound AI prepared by ICAD, and this case is presented by Dr. Grevenholt.
My name is Axel Grevenholt. I'm a radiologist from Germany, and I would like to present to you on profound AI and profound AI risk case study. The patient's history was a 73-year-old woman came for opportunistic screening in October 2020. Before she went to the screening program regularly, in 2009, 11, 13, and 15. The next screening with regular interval would have been in 2017, but the woman turned 70 in 2017, so did not get invited. In October 2020, she came without symptoms for routine diagnostic mammography, opportunistic screening, choosing to opt for 3D mammography on her own expenses. I would like to show you the evolution of the lesion in the CC view. First, from 2009 to 2015, where we retrospectively then applied all the algorithms Profound AI gave us to demonstrate how it works. Now you see all images with the marked lesion, where the lesion score went up from 33 to 36 to 48 and 50% over the years. I show you the same in the OBL images. The lesion on the right side at 12 o'clock is a well-rounded lesion, which was dismissed by the radiologists because it didn't have any changes to the priors. And when we applied Profound AI retrospectively, we could see that the lesion scores and the K-scores here did go up over the years, moderately increased from 36 over 38, then to 58 and to 99%. Now, Tomosynthesis of 2020, read with Profound AI, showed a lesion on the right side at 12 o'clock. It was well marked and the lesion score was 86 in the CC and 80 in the MLO. And the K-score overall was 98. This was at the time of diagnosis. Histopathology results showed there was an invasive ductal cancer next to mastopathic tissue, which is displayed in pink. The cancer is displayed in purple. The mammographic images of 2013 and 2015 probably masked the tumor for the radiologist because of superposition of the benign lesion. Profound AI already detected the subtle changes to this area and assigned higher lesion scores and a higher K-score. When retrospectively applying Profound AI risk, we could see that the risk increased gradually from 2009 to 2015 and went from moderate to high in 2013. In this chart, you can see all the K-scores, lesion scores, and risk scores over the years, how they developed. And what you can clearly see is that all scores went up gradually every time the woman came for a screening, and also, of course, when she came for her diagnostic mammogram. The graph on the right side shows you how a risk developed in the years between 2011 and 2015. The blue line demonstrates the average risk of a woman of this age group, and the green line demonstrates the individual risk of the woman, which increased very high from 2011 to 2013 and from 2013 to 2015 again. So what is the conclusion? If in 2013, because of the high Profound AI risk score, supplemental screening, for example, ultrasound, CSM, or MRI would have been added, there is a high probability that a very small cancer could have been found. If in 2015, because of the high scores both in Profound AI risk and Profound 2D supplemental screening would have been added, the cancer would have certainly been discovered. In 2020, 5 years later, the diagnostic exam with Profound 3D revealed the correct lesion with a very high K-score and a very high lesion score. Invasive ductal carcinoma was confirmed by the histopathology report. In this example, the cancer diagnosis would have been detected 5 years earlier in 2015. Optimally, it could have have even been detected 7 years earlier in 2013, if Profound AI and Profound AI Risk would have been available, applied, and used as a decision tool for supplemental screening. Thank you very much. For further inquiries and information, please go to ICAT's website.
And now the clinical comments. How do breast surgeons evaluate the AI technologies concerning early detection and risk stratification? We have two commentators. Professor Keramopoulos is a gynecologist, breast surgeon, professor in the Athens University, head of the first breast clinic at Iaso Maternity Hospital, and Dr. Mavroudis, who is a consultant, gynecologist, consultant breast surgeon in Henry D9 Hospital in Athens. First, Professor Keramopoulos.
Ακούτε?
We hear very well.
Okay. Well, very impressive and interested this session from AI. This AI is a very useful tool for mass screening, for mass mammography screening. But maybe this mammography screening avoids the use of other diagnostic methods like ultrasound and clinical examination. And it provides a method, a medical method type McDonald's type, useful for mass screening, if you say so. But I think that the screening is not mammography screening. To achieve the optimum of sensitivity to find a tumor, not a cancer, a tumor or an architectural structure, destruction, is to combine the combination of methods: mammography, ultrasound, clinical examination, and sometimes MRI. That is to achieve the optimum sensitivity. And it's not the purpose, it's the target is not to make a diagnosis of a cancer. Diagnosis is a pathological matter. The target is to find some destruction in breast, a tumor or architectural or calcification or other things. That's it's very interesting. It's a tool, but it's not the only tool.
What about risk? AI risk stratification?
What do you mean? Oh, okay. It's a tool. What I said, I cannot say. The certification.
Do you find it useful for the future?
Of course, it's a tool, but it's not the only tool. And the algorithms doesn't replace the experience and quality of a good doctor.
Wouldn't it be a problem to announce in a woman that comes for routine mammography that in 2 years she's going to have a breast cancer in a percentage of perhaps 70%? Isn't it a difficult discussion to make to women such a risk evaluation by the mammography image?
I think it's very difficult to discuss that 70%. If she, I cannot understand what you exactly means, that you can provide to see if a woman has the risk of 70% with a mammography only.
In AI risk tool that Professor Hall has presented just before, the mammographic image can have a risk evaluation. A short-term risk evaluation for the risk of the woman to have breast cancer in the next 2 years. And if the risk is high, you have to tell to a woman that now the mammography is normal, but in 2 years, she has a high probability to have a breast cancer. Isn't this a problem, a communication, let's say, problem?
It is definitely a problem, but if you think about it, the cardiologists, they've been doing this for 30, 40 years. They've been measuring blood pressure, and they're telling people that you have a high blood pressure and the risk that you develop a stroke or a myocardial infarction is increased. Therefore, you should take this pill. Or you have a high cholesterol, and therefore you should take statins. So in the cardiology world, this is what they do on a daily basis. We are not as used to risk prediction and prevention in the oncology world.
It's a change for us. I think it is difficult.
It is. And also, as mentioned, I mean, any risk tool or AI, whatever it is, will never replace doctors. That's not what it should do. That's not the aim of it. It should be supporting the decision of doctors to help them to make the best decisions that we could possibly make. But doctors will never be replaced.
Yes, but if they have the method of AI, maybe they are not very good educated. They are not doctors. They are technicians only.
Yes, it's
like cytology.
I completely agree. I've been working with people who are completely technically oriented. They don't know what a cancer is. They don't know the clinical setting. They don't understand the interaction with patients. And they should be used, and you can't say treated, but they should be used as technicians. But all of these developments has to be performed in collaboration with the clinicians. Otherwise, they're worthless.
Okay, I agree.
Yeah.
Dr. Mavroudis?
Yes, I want to thank the previous speakers for the excellent presentations. And I want to say that about the DBT, the digital breast tomosynthesis, read by an AI algorithm is not inferior in terms of cancer detection to double reading 2D FFDM as it is done today, no? And there is evidence that AI can reduce reading time in the context of DBT screening. You understand?
Yes.
Because we know that is one of the drawbacks for the implementation of DBT is the increasing number of images in the read. The additional reading time will be even larger if the double reading policy persists. So this is the evidence that the AI can reduce reading. I think this is very important.
This is the main problem, that DBT cannot be used in wide range for screening, because not too many machines are existing all over the world. But yes, it is an exam that has a lot of slices, a lot of images, and needs time for diagnosis. AI is helping this time diagnosis, cutting it by 50%. So this is a future to use DBT in screening more easily. The second is diagnostic confidence. Because we see too many images in DBT, we're tired. If we have to diagnose 20 or 30 DBTs per day, we are totally exhausted. AI is helping the diagnostic confidence. If you have a tool that can help you with the sensitivity and specificity, you become better doctor in diagnosis. So this is the help, and perhaps this is the way for a wider use of DBT in screening in the future.
Yes, this is true.
So thank you. We have to close the table due to time. Thank you all, and I hope to have you in a future webinar again. And now we pass the microphone to Dr. Ioannidou and Dr. Mundrea for the second table, for the second round table. Thank you.